Okay, let's get this over with. Let's get this done. Okay, we've got to go over chronic kidney disease, which you might be wondering, well, did we kind of go over that last time? Yes, we did. Yes, we did. Literally, the big thing we've got to go over this time is peritoneal dialysis. Oh my goodness, what? Yeah. And there's a lot of stuff involved in that. But let's just jump right into it. A brief review over chronic kidney disease. So, chronic kidney disease is when something goes wrong over a longer period of time. What? That's crazy. I know. This can have a gradual onset, which is going to be months to years. And with that gradual onset, you're going to also see that gradual increase of symptoms as time goes on. This is a permanent loss. Now, usually when you have this chronic problem, there's a chance that you might not even really see it for a little bit of time, just simply because your kidneys are pretty resilient. They can work pretty well up until usually the very end, usually when you've lost 90 to 95% of your nephrons, do they go, hey, we can't do this anymore. Can we please have some more help? Yeah. But once you start losing that kidney function, you can't really get it back. So it's really important to kind of keep an eye on this and to talk about what we can do to help ease the pressure off the kidneys and all that stuff. There's 5 stages based on the GFR, which we talked about in the last lecture. Usually stages 1 to 2, you don't really notice anything. There's not really and truly changes in your ability to filter and stuff. Usually starting at that 65 to 70% with stages 3 to 5, do you see the big issues where, okay, well, now we're starting to have issues with like this strange tiredness and maybe I'm a little itchy and yeah. So these people as well who have chronic kidney disease are more likely to have a fistula. We talked about acute kidney disease, and we kind of talked about a fistula during that time, but really and truly, if you've got an acute kidney injury, it's not been caused by, like, years and years of having diabetes or some sort of, like, heart failure or hypertension. It's very likely that they'll just say, hey, we'll just put, like, a dialysis catheter in you, and we can take it out once everything is back to normal. Well, with this person with chronic kidney disease, they may not get their function back. And so it's important that if they're going in for dialysis all the time, they need to have a site where they can access it a little bit faster and easier. That can be useful. So there is that. Some like reasons you might get renal failure, like chronic use of NSAIDs. Like let's say you take, I don't know, a freaking ibuprofen 4 times a day for like 3 years. Hey, it could happen. I'm not going to sit here and say it can't. That would be a reason for somebody to potentially have some like big kidney damage there. Some antibiotics can cause chronic kidney disease. Diabetes, though, is our number one cause, just because it's very prevalent and it messes up the microvascular and even sometimes macrovascular parts, but especially that microvascular space. It's going to make it so that the kidneys are going to be hurt, because the kidneys need blood as much as anything else. And if those if that's the vascularity of the renal system, the renal system is hindered for a long period of time, there's a lot of gunk that's being flushed through it. The blood vessels are becoming harder and more stripped and everything. They're not getting as much blood as they used to. Can cause chronic kidney failure. Heart failure as well, just because of like long-term, just slow ischemia. In acute kidney injury, it's like a very quick lack of perfusion. In a chronic kidney disease, your cells just sort of slowly are kind of asphyxiated, like a frog in the boiling water. And so oftentimes by the time you've realized it, a lot of the damage has already been done. And then, of course, hypertension for the same reasons. Now, in chronic kidney disease, this is something we just simply have to kind of deal with. For a person with chronic kidney disease, they need to be knowing that they're going to have to change a lot of aspects of their lifestyle so that they can kind of keep what kidney function they have for as long as possible. We have here some nutrition changes, different labs that might be affected, and then medications that might be given for somebody who has chronic kidney disease. So, to start, protein. Okay, so if you've got chronic kidney disease and you're not getting dialysis, okay, usually proteins are kind of going to be contraindicated in the diet. You may be wanting to have somebody have lower proteins in the diet, okay? Because that protein is going to increase. It's going to float through into the kidneys, and you're going to pee out the protein. It's not going to be very good. But after dialysis begins, we're kind of less concerned about that protein as an issue. We have a thing here. We're not going to get to peritoneal dialysis quite yet. We're going to go to dietary interventions, especially if that person is on dialysis. It's okay for them to have protein. In fact, we want them to have about 90 grams of protein per day, which is about the same amount as you would want to have normally, 90 grams per day, which you can find in lean meats, eggs, poultry, tofu, legumes, all that good stuff. But just kind of remember the difference there. If you haven't started dialysis yet, usually you're not going to want a high-protein diet. I'm going to look up exactly why that is, just so that we can know, what the frick is going on here. Okay. Why low-protein diet for kidney disease? Reduces the amount of protein waste the kidneys need to process. Yep. Help the kidneys function longer and more effectively. Gotcha. Because, of course, urea is being produced when you go and metabolize kidneys, which is all secreted through the kidneys. And if the kidneys aren't working well, it can build up in the blood, causing more damage and blah, 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 blah. Okay, that makes sense. But yeah, once you start dialysis, though, you're usually doing dialysis at least like once or twice a week, sometimes even every night if you're doing like a continuous thing, which we'll talk about. But that allows for your body to get rid of the wastes more effectively, so you do actually want to have protein in your diet. But remember, that's only when you've started dialysis. Potassium may need to be increased based on the patient's labs, but once again, that it really does just depend on the patient's labs. Like if the patient has fine potassium, don't worry about it. If the patient doesn't have fine potassium, you probably should make sure they have some sort of, or that they're having that in their diet. Yeah, I mean, they say on NCLEX, like, if you don't have it, especially in this renal diet or whatever, with this person with dialysis, if in doubt, yeah, potassium's not a bad thing if they're on dialysis and they need that. And I don't know why it's not allowing me to go into that other one, which is kind of dumb. Yeah, increase potassium to 3 to 4 grams per day. You can find that in bananas, oranges, potatoes, tomatoes, spinach, all that good stuff. But, yeah, it depends on the labs, really and truly. But if there's no labs and they're asking, then, yeah, a little bit more potassium is okay. Limit phosphorus, because remember, calcium and phosphorus are like enemies. So whenever calcium is up, phosphorus is down, and vice versa, okay? And because our kidneys have a really big part to play in calcium absorption, specifically because the kidneys produce calciferon or whatever. calciferol, yeah, which allows our GI system to uptake calcium more effectively because that calciferol is essentially the active form of vitamin D in our bodies. So, we want to limit phosphorus because we are already worrying about having a low calcium, and phosphorus will be increased, right, because we have got a low calcium. So we want to limit phosphorus in the diet. I don't know if they have something there about phosphorus. Yep. So we want to limit phosphorus to less than 1,200 milligrams per day. We want to avoid dairy, nuts, seeds, whole grains, especially sodas. Sodas have phosphorus in them. And so if we're talking about having a phosphorus restriction, those are the foods we're going to want to avoid. So less than 1,200 milligrams per day. We also want to limit sodium. We are going to be on a fluid restriction and also limiting sugar because sugar is an inflammatory thing, especially if we've got a history of diabetes. We do not need more of that stuff in our body to, as not even that, but also there's those are parts that go like these are all in the dialysate. Okay, we've got fluids in the dialysate and like sugars and all of that good stuff because we need to make that dialysate hypertonic so that it draws fluid into it, draws the wastes into it. Okay, so this person will have those things like hanging around in their body kind of all the time ish. And so because we've got plenty of those things, we have plenty of phosphorus, plenty of sodium, plenty of fluid, plenty of sugar, just because those are in the dialysate, we don't need much more of that in our diet. So things to keep in mind, as well as those are also things that in general, like when it comes to kidney failure, you've got plenty of. You do not need more of that. Fluid restriction in kidney disease or kidney failure is calculated by adding 500 milliliters to the amount of urinary output a person has had in 24 hours. So if you peed like 1,000 milliliters in 24 hours, then you would have a fluid restriction of 1,500 milliliters the next day. And then this person is going to be on a sodium restriction of 1,500 milliliters, which is not that much, actually. That is like a fourth of a teaspoon. So that's like a pinch of salt. Now, let's think about this for a minute, right? Because usually when we're talking about electrolytes, we're like, oh, well, if you're having a salt, you're on a salt restriction, we're also worrying about potassium, and so a lot of times salt substitutes will have potassium in them. Well, in this case, we maybe want a little bit more potassium in our diet, so salt substitutes would be okay in this case. That makes sense to me. Labs affected in chronic kidney disease. Okay, so we talked about how in acute kidney disease, the labs that we're going to be seeing changes in are sodium, potassium, of course, our BUN, a little bit of our creatinine. But we talked about not really seeing changes in our calcium and phosphorus because those take a little bit longer to change. If you see that calcium is low and phosphorus is high in somebody who has a suspected kidney injury, then you can think, hey, well, maybe this has been a more long-term problem. Just because it takes longer for those things to really change. And that's where we talk about, you don't get osteoporosis in a day, you don't get renal osteodystrophy in a day, and so, that whole calcium and phosphorus thing, if you see that, it's more of indicative of a chronic issue. Hemoglobin and hematocrit will also be lower just because our ability to create red blood cells in chronic kidney disease will be decreased since our kidneys have such a role to play in the production and secretion of erythropoietin, which is the hormone that tells our bones to create more red blood cells. And if our kidneys are not able to function properly, the production of that hormone and in turn the production of red blood cells will go down. Platelets are lower, and we talked about why platelets can be lower, and it just comes down to like our clotting factors also being damaged and inhibited by all the wastes that are in our bloodstream now that we've got this chronic kidney problem. Yeah, so basically. Medications. Okay, so there's four kinds of medications we're going to kind of go over. First one is erythropoietin, which remember is that hormone that stimulates red blood cell production. Now, erythropoietin is given sub-Q about like once a week. Now, the thing about erythropoietin is that it's a hormone and it causes the creation of red blood cells. Red blood cells have a period of time where they're not really useful. They sort of just float around. And I don't remember exactly what it's called. But I'm going to look it up. Becoming a red blood cell. An RBS. Oh, look at that. They already freaking knew. Ha ha ha. Okay, look at that. Okay, so reticulocyte, immature red blood cell released into the bloodstream from a bone marrow. I freaking knew it, bro. I didn't know what it was called because I forgot that much, but I did know that they just float around like freeloaders. Anyway, so, but it takes about 2 weeks for the red blood cells to be created and ready to rock and roll. So this person can be receiving erythropoietin but not really see a change in their red blood cell counts and maybe even anemia issues for about 2 weeks. And they'll be taking this for a pretty long time so that, I mean, unless the kidneys make an amazing turnaround, half of this is just because the kidneys can't work, and it's like, well, now we got to do something outside. If the kidneys can't regulate themselves, we'll have to make sure that we can add things to the body that help us do the kidney's job, basically. Diuretics as long as possible. Okay, diuretics are just going to help to get that excess fluid out. If the kidneys aren't able to filter very well, they're not able to, get the fluid out as effectively, then this person may be on diuretics just to help kick the kidneys in the pants a little bit and say, hey, get going. But, yeah. I mean, I want to see how long will someone with chronic kidney disease be on diuretics. Exact duration just depends on the case. When fluid retention becomes more prominent. Who is on dialysis? Okay, just depends on the function of their kidney and how much fluid they're retaining. So if they just continue to retain a lot of fluid, clinicians will be like, well, you just need diuretics, probably for a really long time. It's rough. And then, of course, antihypertensives. Yes. And I know that hypertension hurts the kidneys. Why would someone with CKD be on antihypertensive drugs? I want to see if there's any other reason. Okay, slows the progression. Okay, so that's just slowing their progression, basically. Yes, because high blood pressure hurts the kidneys. Same reason that high blood pressure hurts any other organ in your body, but especially the kidneys, because the kidneys get a lot of blood, and they're the ones who have to cleanse it. And if the blood is just like ripping apart to shreds those poor capillaries, they're not going to be able to do their job very well. Statins. Okay. La la la. Statins. They exert an anti-inflammatory effect that is important to improving complications, in reducing mortality, and slowing progression. Interesting. So they help to protect the heart. They help to reduce inflammation. Gotcha. So statins can also be used to help to decrease the risk of it getting worse and all that other good stuff. Rad. Yep. Those are our anti-cholesterol meds: atorvastatin, lovastatin, simvastatin, pravastatin, rosuvastatin, antistatins. They'll also get phosphate binders, and the reason that they get phosphate binders is so that because our phosphate and our calcium bind together. That's what they kind of have this anti-effect against each other. Phosphate binders, they keep phosphorus from binding to calcium so that we've got a higher extracellular calcium going on, which is good for our electrolyte levels. So that's nice. La la la. And those are case study things. It's not here. Okay, here's our big next part here. It's peritoneal dialysis. Okay, so we talked about the other type of dialysis, which is just being on a dialysis machine. You go in, they stick a thing in your vein / artery / fistula thing, double lumen catheter, and in doing that, they filter your blood for you. Well, in peritoneal dialysis, la la la. It is essentially the same thing, except that it goes about it in a different way. It removes waste and excess fluid, acts to replace the kidney function in patients with chronic kidney disease. Okay. Now, in peritoneal dialysis, they stick this catheter in this person's abdominal, space. Okay. And when that happens, they infuse this thing called dialysate, okay? And this dialysate is a hypertonic solution that helps to draw out, okay? It helps to draw out from the abdomen all the waste products that are floating around in the body. It's a highly vascular space, and so the stuff in there goes... all the waste that are all filtering around and all that extra fluid, they look at that dialysate and they go, well, that's hypertonic. We got to leave this place and go to there so that we can have more of an osmotic balance, okay? So, in doing that, this person gets the dialysate, it sits around in the abdomen for a little bit, and then they drain it, all right? They literally let the dialysate sit around in the abdomen for a little bit, and then drain it into a waste bag. And the waste bag kind of looks like a pee bag, but it ain't pee, I promise you that. Well, it could have been pee if the kidneys were working, but it's not now, so. But yeah. They call it dwell time, which is when they've infused all this dialysate and it's just sitting around in the abdomen. And that's prescribed by the physician, but once that prescribed amount of time is finished, then they just drain that excess fluid, and they repeat this process 3 to 4 times a day. Okay, things to know about this procedure. Actually, there's a lot of things to know about this procedure. There's a lot of things that can go wrong, a lot of things we need to be considerate of. Let's start first and foremost at the exit site, okay? This is inserted into the patient's abdomen, which is supposed to be a completely sterile environment. We've learned about what happens when it's not stable because, unfortunately, they get peritonitis. La 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 la. Sorry, people are texting me these days. Anyways, checking that exit site. So if that site was to ever get infected, or if that site was to ever, if that, I don't know, the catheter inside was to ever puncture something and start bleeding, bad things would happen really quickly, okay? If there's any sort of redness, swelling, and nasty drainage coming from that exit site, the patient needs to call the doctor, okay? So if they're at home and they catch it, they need to call the doctor because they can't have the dialysate be infused. So now we're at risk for putting we're messing with that, maybe even making it so that infection spreads deeper into the abdominal cavity and making this person go into a risk for having a septic problem. If they come in, we need to tell the doctor in the same way, because we cannot infuse fluid into a place that's been what we're worried is looking like that. If it looks like that, there's absolutely no way we're going to be infusing fluid. No, no, no. Another thing that can show that we've got some sort of infectious problem is if we've got a cloudy drainage. That's pretty cloudy. I can't really see through that at all. That's a sign that we've got some sort of infection brewing, and that's bad, because that cavity is supposed to be completely septic. It's completely supposed to be aseptic. Like, there's not supposed to be anything in there. And if we're putting stuff in there, that can cause problems real quick. So, that's the exit site. Now, when it comes to the actual procedure, we need to make sure to weigh the patient first, because we need to see how much fluid how much they weighed beforehand, okay, before the procedure, how much they weighed after getting that fluid all in, put all up in them, and then how much fluid that they lost once we took once we drained them. So we need to make sure that they're staying, they're not losing too much weight, or if they are, because they gotta lose some weight, but if they're losing way too much, or they're just continuing to lose and lose and lose, we want to make sure that we keep an eye on that, okay? And the dialysate also needs to be warmed. Now, I don't know what happens when the dialysate isn't warmed. Why do we need to warm dialysate? Hold on. Prevent a drop in body temperature. Makes sense, because of course, right, the dialysate will be warmed up to the patient's body temperature. It won't be like boiling hot or anything, obviously. And that's just done so that the patient's body temperature doesn't like drop, because it could be super uncomfortable and cold. Makes sense. Like, that's the thing, is like, it makes so much sense, and it's like, I just wanted to make sure there wasn't like no, they'll die, like, Anyway, hang and connect dialysate, open clamp. Once the fluid's been infused, the patient can just run about their day. They'll have that dwell time, all that good stuff. Then the patient will come back, do their thing, and they will have the drainage happen. Drainage bag will be connected, and then it'll start getting drained out. And then after that, they're going to infuse more fluid. They're going to infuse more fluid. Like, after it's been drained, they're just going to infuse the next bag. And, then it's going to be all cool and awesome. Exit site needs to be cleaned regularly with, like, warm, soapy water before peritoneal dialysis. They'll also have, like, at this catheter, it's going to have, like, a special cap that's got some sort of, like, I don't know, iodine or fancy thing where it's, like, going to prevent that infection. Because if there's an infection in this peritoneal cavity, we got bad stuff. We also want to observe the output color. The output color should be clear and kind of yellow, okay? It should look like pee without any problem. It just looks beautiful, okay? Anytime there's anything that's like not that, okay, we're a little bit worrying. I mean, if it's a little bit darker, okay. But like if we're talking cloudy, we're worrying. We're worrying about an infection. If it's bloody, we're worrying about perforation, like bleeding. And of course, if it's brown, then we're worrying we've perforated the GI tract, and like that person could go into sepsis at any moment. Literally any moment. This is a medical emergency. If you ever see brown in the bag, that person needs to go to an ER, needs to go to the hospital immediately. They will probably be in the ICU, because that's terrible. That's terrifying. We need to make sure that gets fixed, because that could turn into being more pretty bad really quick. If there's signs of an infection, patient needs to call the doctor before the procedure, because that needs to be managed before peritoneal dialysis is performed, not informed. And we talked about that. Now, of course, if they don't catch it and you catch it, of course, you are not infusing fluid if there's any signs or symptoms of infection at the site specifically. Now, the fluid here is not going to be removed as rapidly as in hemodialysis, okay? Because remember, it has to dwell, it has to sit around for a couple of hours as the doctor prescribes before being drained out. So, um, we are, yeah, we are going to be worrying a little bit about constipation because this is all in the abdominal cavity. Now, even though we're taking stuff from the like the blood vessel, like vascular system, the waste from there, it can have an effect on our GI tract because it does pull fluid from there. So we are worrying a little bit about constipation. This person might get some stool softeners if the constipation gets pretty bad. Or just starts getting worse. We obviously don't want to like let it get super bad before doing anything about it. And then, of course, because it takes a longer period of time and it doesn't happen at the blood level, like it happens kind of outside of that in the abdominal cavity, this person can take their meds during the process. We're not worrying about their meds being like filtered out of the bloodstream and stuff because of whatever. That's not how this is gonna work. This person can take medications. It will be fine because we're not doing this at the blood level. The changes are happening because of osmosis. However, we're not doing it in a vein, an artery/vein. Okay, so this is a continuous ambulatory or this is like an ambulatory peritoneal dialysis moment. This person, she can get up, rock around. She just has to kind of carry her infusion waste bag thing with her. It can be kind of tough because you can't take that everywhere, but it can allow you to do things around the house and kind of exist outside of your peritoneal dialysis. And somebody with chronic kidney disease is going to probably be doing this all the time. Now the question is, well, this is kind of inconvenient. I'm doing this for 3 to 4 times a day. That leaves me only so much time in the day to do what I need to do outside of being at home. Well, that's where this continuous automatic or the peritoneal dialysis comes around. Now remember, the other one is ambulatory. That's what that A stands for, and this one stands for continuous. Now this one, it doesn't have ambulatory, so this person is sitting down, okay? But the reason that this can be really useful is that it does this whole process automatically. This person is hooked up to a machine. It's hooked up in the exact same way. It's got an exit site area on the abdomen, and this cycler machine does the whole process of this on its own. It infuses, grabs up the waste, puts in whatever, grabs up the waste, blah, 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 all over and over again, okay? Now, usually, and this is great because patients can just do this at night. They have to do this 3 to 4 times a day anyway, and so you're like, well, that's 3 to 4 times a day. Let's just do it at night when you're supposed to be asleep, okay? So it fills up with 4 bags of fluid. 4 bags of fluid, because remember, we're doing this 3 or 4 times a day. They'll just do this all at night. It will instill the fluid at night, let it dwell, and drain it while the patient is sleeping. It does it all on its own. The patient can be totally asleep and totally just, enjoying their rest and be able to go about their day as normal when they wake up. This process takes about 8 to 10 hours. Now, the patient can, if they need to, disconnect for a short period of time and use the restroom if they want to. Overall, though, this should be a fairly uninterrupted process, just so that they don't get behind on the schedule of the infusing and draining and everything. Overall, though, it's very convenient for patients with chronic kidney disease. Can help them to live a fairly normal life. We talked about the infectious complications. Let's talk about what to do if the infusion stops, okay? If the infusion stops, there's a couple of things that you will never do. Never, ever pull this catheter out. Don't rotate it. Don't push it in. Don't pull it out. Don't do anything. Do not mess with it at all, okay? More than likely, if the infusion stops, it's a positioning issue. So kind of direct the patient to kind of move so that they're not putting any pressure on that area, so that, that area is fairly, so that the tube isn't being put any pressure on or whatever. It's 9 times out of 10 going to be a positioning thing. Just have them reposition. Do not pull it out. Do not push it in. Do not mess around with that cable. Don't do it. Don't move the catheter. If the site ever starts to leak, that is a bad thing. The site should never leak. We need to call the doctor and figure out what's wrong, so that they can figure out what's going on. But that's not, we don't have like indications for that. We don't have like a thing. Of course, though, if the site is leaking, we would probably rather not, we'd probably want to stop the infusion. I'll check that. Do you stop dialysate infusion if exit site is leaking in PD? Yes, should immediately stop it. That's what I figured. And then, of course, this is serious. This is really, really bad, and we do not want this to be leaking. So call the doctor immediately, stop the infusion so that they can figure out what's wrong. They might have to, I don't know, go back to, they say temporary peritoneal rest, catheter adjustments. That's a doctor thing. And then the doctor may also want to replace the catheter. But all our job is to do as nurses is to look at that and say, oh, that's leaking, stop it, call the doctor. Okay, there's this, then we gotta do math. Wow, yeehaw, math. There will be questions about this peritoneal dialysis math on the exam. It's not rocket science or brain surgery, okay? Measuring output. We measure output for somebody who's on peritoneal dialysis by weighing the outflow bag. Okay? We weigh the outflow bag. Okay? That's the waste bag. One thing to consider, there is 1,000 milliliters in 1 kilogram. Okay, yeehaw. 1 kilogram equal to 1 liter. Let's keep that in mind, okay? Now, to calculate how much output this person has had doing peritoneal dialysis, we take the volume of the bag that has been infused. In this case, it's 2,500 milliliters. We take that and consider that that has been infused in all the way, okay? So that's 2.5 kilograms has been infused in the patient. After the patient has been drained, so to speak, they weigh the drainage bag, the waste bag, and find out that the bag is 3.2 kilograms, or 3,200 milliliters. Okay, so to figure out what their output is, you take this number of output, which would be 3,200 milliliters, and subtract from that the amount of fluid infused from the dialysate. Amount of dialysate infused, which here is 2,500. Now you subtract those two numbers, and then whatever you get as their difference is the number that we can calculate as our output. In this case, it was 700 milliliters. Not rocket science, not brain surgery. Just know how to do it, know the conversion factor so you can get a free point on the exam. And then we're going to go over these lab changes one more time because it's important to know the lab changes, okay? Now, I've put here in the side the things that change with acute kidney injury. And you'll notice that most things don't. Most things don't. Because when all these things have had a problem, it's more likely that it's been a problem for a lot longer. But let's talk about potassium. It's going to be high, okay, because we're not able to excrete it as effectively. Sodium is going to be high for the exact same reason. These are both things that change quickly and can be seen in an acute kidney injury. Magnesium will also be high simply because it also cannot be excreted effectively, although it will not be seen in acute kidney injury necessarily. BUN and creatinine will also be seen in an acute kidney injury, and they'll also be high simply because, let's talk about urea and nitrogen. Blood urea nitrogen will be high because we can't get rid of it. That's a waste product. We don't want our BUN to be high. And then creatinine will also be high, as it shows that there's been damage set to the kidneys. Creatinine gets created when there's muscle waste, and so if we can't get rid of it because our kidneys cannot function properly, we will have high creatinine. Uric acid. Uric acid is it's a measure of the acid in our urine. I want to check that and make sure. It is literally acid in our urine. Okay, cool. Filtered by the kidneys and excreted in the urine. Helps maintain pH balance of blood. Well, not in this case. In this case, we've got high uric acid because we can't excrete and filter with our kidneys. So our uric acid will be high whether we like it or not because of the waste product produced by the breakdown of purines, which is part of the protein breakdown cycle. So platelets will be low. Glomerular filtration rate will be low and will get lower as our kidneys get worse. Iron will be also low. Iron infusions are really high risk also, so if you're ever giving iron, make sure to stay with that patient because they could have an anaphylactic reaction. And of course, if that happens, stop the infusion. Stop it immediately and jump into life-saving measures of opening up their airway and everything else. Red blood cells will also be low in chronic kidney disease because of our erythropoietin. And I want to check why iron will be low. I have a feeling it's similar. Well, look at that. Because iron is all up in our blood cells. In our hemes, you could say. So, due to a process called functional iron deficiency, the body cannot effectively utilize available iron stores caused by chronic inflammation and increased hepcidin levels in CKD patients. What the freak is that? Small protein hormone produced in the liver that plays a crucial role in regulating iron metabolism. Okay. Kidneys are responsible for producing erythropoietin, which is crucial for red blood cell production. This drops, increasing the chance for red blood. Blah, 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 blah. Okay, hormone that regulates iron absorption. So basically, the chronic kidney disease causes a problem with this elevated hepcidin, which means that it overregulates iron absorption and says, no iron for you. And so then we have low iron. Makes sense. Hemoglobin will also be low. I wonder why, because of the red blood cells. And then calcium. Calcium will be low. We talked about calcium and how our calcium will be low because our body cannot properly do the extra absorption that having the calciferol, that is our active form of vitamin D, that our kidneys make. We won't have that, so we will have lower calcium. Phosphorus will be high because phosphorus is when phosphorus is high, calcium is low, and when calcium is low, phosphorus is high. So we'll have high phosphorus because it binds to all sorts of things, specifically calcium. Vitamin D, yeah, calciferol moment. And then urinalysis, we'll just see proteins in our urine. So what things can dialysis help with? Some common things to think about when we're asking what can dialysis help with. Dialysis doesn't really add anything. When a person is receiving dialysis, they're not going to be gaining things. So if we've got something that is low, we can't really do much to make it better, to add things to it, okay? So dialysis can help with high potassium, high sodium, high magnesium, having a high BUN, having a high creatinine, having a high uric acid, having a high phosphorus, okay? Dialysis doesn't add anything, so dialysis can't add red blood cells, it can't add calcium, can't add vitamin D, or can't add platelets. They have here that dialysis can help the glomerular filtration rate, but it's indirect. Okay, the reason that the glomerular filtration rate gets higher is simply because it's taking less pressure from our kidneys because we've had dialysis. Dialysis doesn't directly make the glomerular filtration rate get better. If it did, people wouldn't have to be on dialysis for a long time, but they do. So here's our kidney transplant. Kidney transplants any sort of transplant is a pretty hardcore procedure because our bodies are very xenophobic. They don't like things that don't have our name tags on them, okay? Some things about kidney transplant to know. Kidneys are checked for 6 different antigens before they're given to the person who's going to receive them. So they talked about that in class. That's kind of cool. The transplant of this kidney has to happen 24 to 48 hours after it's removed from the donor. Kind of a tight schedule there. When they get this kidney, which by the way, they'll leave those other 2 kidneys in there and just put this new one down there below. Kind of cool. You'll have 3 ureters. Kind of rad. But, okay, once they get this new organ, the patient will be on immunosuppressants probably forever. Probably forever, so that the body doesn't wake up and realize that that kidney's not supposed to be there. They might be on prednisone, some other heavy duty ones. Any signs of infection, okay, or rejection are an emergency. Now remember, if they are on immunosuppressants, their signs and symptoms of infection might be dulled a little bit. Tiny increases or like small increases in temperature, a feeling of malaise, anxiety, any sort of thing like that, that's a big deal. When we're talking about rejection, flank pain is a huge one. If you hear about flank pain, oh, we got a problem. Immediately you're going to immediately you're going in to see what's wrong. Calling the doctor and saying, flank pain. What do we do? You know, we got to worry about that. Acute rejection. Now we'll talk about acute and chronic rejection, but acute rejection usually will happen quickly, about a week or the first week or a month from that the transplant. Its signs and symptoms are going to be more abrupt because it's an acute thing, right? So you're going to have an immediate decrease in urine output, a slightly high temperature. Remember, it's slightly high because they're on immunosuppressants. Rising blood pressure, flank tenderness, that's a huge one. Malaise, quick increase of BUN, creatinine, and potassium. Remember, quick increase because it's an acute rejection. So some of our signs and symptoms of an acute kidney injury. Think about it like that. In an acute rejection, you'll have those same signs and symptoms of acute kidney injury with that flank tenderness and malaise. In a chronic rejection, it can take several months to a year for the body to figure out that that kidney is not supposed to be there. And you're going to see a gradual increase in BUN, gradual increase in creatinine, gradual increase in those electrolytes. You're going to see some protein in the urine. And what do we see there is that, oh, those are our signs and symptoms of kidney failure or a chronic kidney disease. Okay? So just things to think about. And of course, immediately post-op, we're going to be giving those loop osmotic diuretics so that they can help them pee, because we want to get them practiced in using this nice fancy liver. Or sorry, not liver. Nice fancy kidney. Oh, goodness. Okay. Bladder training may be necessary. Watch for signs of retention and incontinence. And I'm going to delete this extra page that I put here. So silly. I'm going to check this extra one right here. See if we're missing anything. Yeah. Trying to think if there's anything big that we've missed here. Yeah, I mean, of course, if they want to travel around, they have to just make sure they take their stuff with them because they need to still be able to get their peritoneal dialysis. Other than that, though, it's a little shorter because we've talked about a kidney injury last time, and this is just kidney injury over a longer period of time. Cool. Well done.